Thank you very much, and thank you for the invitation to speak with you today. So I'm going to be talking about the early real-life experiences with Benlysta in the clinical practice setting. These are my disclosures. So objectives for the next 20 minutes will be to understand how physicians can look at the potential of biologic treatments for SLE in the real-world setting, and how these results from the BLISS studies correlate with clinical practice. We'll assess real-life outcomes seen in patients receiving Benlysta plus standard of care in clinical practice by drawing on data from the OBSERVE initiative, and reflect on current treatment standards and outcomes and expectations for the future, and how biologic agents may contribute to better outcomes. So, not to hash too much on the where we are now, as Ronald pointed to a little while ago, but we've got a long way to go. This slide really illustrates the disease burden, especially in the younger population with lupus. If you are a young person diagnosed in your teens or early 20s, you have an overall almost 20% chance of dying an early death relative to the general population. If, like the majority of our patients are diagnosed before the age of 40, it goes to around 8%. So clearly there's a lot of room. Additionally, if we look at morbidity, we can see that organ damage accumulates rather rapidly. Within 5 years, nearly a third of our patients accumulate some form of organ damage, and within 10 years, about half. We look at some of the more economic costs to this, and I know we've seen some cost estimates out of Sweden. This is workplace estimates of loss, and we can see that overall, about at 4 years from their diagnosis, nearly a third of patients reported that they had to stop working. Indeed, this was drawn mostly from complaints of musculoskeletal disease, followed second by neuropsychiatric and thrombotic manifestations from their lupus. So the real questions we have is, can biologics change this paradigm? Well, certainly it's too early to tell. It has taken almost a decade now with the tumor necrosis factor antagonist therapy and RA for us to really start to address this. And one would argue that it's going to take maybe that long or longer to address whether or not biologics can change this in lupus patients as well. And the other question is how are we going to define success? And this is stuff that is being looked at by a number of excellent clinicians and scientists. And this includes steroid use, mortality, organ damage, and health resource utilization. All of these are actually quite integrated with one another as well. So we've talked a long time now about the challenges of randomized controlled trials in systemic lupus erythematosus. We all agree on the incredible heterogeneity of this disease. We know that there are variable courses of the disease within an individual and the group as a whole. We understand that there is a lack of consensually agreed upon endpoints. Overall, it is still considered a relatively uncommon disease, more or less 10 times less common than rheumatoid arthritis. We know that the responses of patients with mild to moderate lupus may be indeed different from those patients with recalcitrant disease. And then there's this requirement to need to demonstrate superiority in the randomized clinical trial setting, not non-inferiority. So can we translate a randomized clinical trial into clinical practice? So the first question we have to ask is, are the outcome measures used in the RCTs meaningful in real life? And so we just heard a nice illustration from Dr. Fury about the SRI and what that really means to be a responder. And so perhaps there is a little room to say, taking some of these outcomes and translating into a meaningful clinical practice, but we don't use an SRI in the clinical practice setting. Second, does the one-size-fit-all approach to randomized control trial apply to our clinical patients? And certainly we tailor therapies much more so than we do for randomized clinical trials. In the RCTs, we've really seen two different arms. We've seen the nephritis trial, and then we've seen the non-nephritis trial. But beyond that, we have not undergone a randomized control trial in a specific subset other than that. And then there's the standard of care background therapies, which has also been alluded to as a potential rationale for the explanation of the small effect size seen in the RCTs that have been completed to date. So this was, again, reiterating the primary endpoints of the BLISS 52 and the BLISS 76. And again, while achieving statistical significance, there was a relatively small effect size. And if we focus just on steroids, again, there was numerically favored the use of belimumab in the BLISS 52 and the BLISS 76 trials, but these were non-statistically significant. And so I'll use this as a point to illustrate kind of how we thought of this during the clinical trial and how it's not really reflective of clinical practice for us. So in the clinical trial, you can see that for the first 24 weeks, we were absolutely at will to change corticosteroid dose to treat the patients as we felt needed. We didn't know if they were getting any of the medications or not, and so we were absolutely allowed to increase this to whatever dose we felt was clinically appropriate. The only mandate is that then by week 44, you get that as close down to baseline as possible. And then we're staring 8 weeks to when the patient can go into an open label extension. And as Richard mentioned earlier, there was not a mandate to decrease the steroid dose for these patients. All we knew is that if you had to increase the dose, or if you had to alter therapy in response to a flare, that patient was then considered a study failure and withdrawn from the clinical trial. So in clinical practice, we'd be more than willing, and actually very advocately would try to withdraw as much steroid as we can. But in the last 8 weeks of clinical trial, when you're staring into an open label extension, when you know your patient can get on a med for which you feel there is a high degree of promise, you are unlikely to aggressively lower steroids for the risk of potential flare. So moving beyond the randomized controlled trials, we'll look a little bit at the open label extension data that Richard also pointed out, and I'll point out to a couple of other slides. Again, this isn't real life, but we're getting closer. These are patients whom are now at least not randomized into a placebo versus treatment arm. Everyone here is getting drug. We're seeing them in the clinical setting. And this is what we observed moving up to now 7 years after inclusion into the open label data. So patients with flares and severe flares, you see that these continue to drop over time. And the mean corticosteroid dose, again, now that you're out of that placebo-controlled phase, we start to now aggressively lower corticosteroids in these patients. So now we'll move into the post-marketing real-life experiences with belimumab. So this is an initiative that my group's undertaking. This is the evaluation of the use of belimumab in clinical practice settings, or the OBSERVE trial. We have presented some of this data at last year's ACR. We'll present a little bit more of it tomorrow during one of the oral presentations. This was a multi-center retrospective medical chart review study, and so as I talked about this data, keep in mind some of the inherent limitations in the study design. We recruited 92 rheumatologists from U.S. non-academic centers, and this is important because this is going to differentiate a little bit the kind of patients that are seen in the United States. You know, we have academic centers where we do get a lot of very severe disease patients, and these are generally going to be rheumatologists from the more practicing community out there in the U.S. They were asked to have been at least treating at least 10 patients, have been in practice for at least 5 years, and have had at least one or more patients whom had gotten belimumab for at least 6 months, and this is about 8 infusions. We did the index date as the first date of belimumab infusion, and we had the physicians assess the 6 months prior compared to the 6 months post. So this is the background of the baseline demographics. If you look on the left-hand column, this is the total cohort. You can see that the mean age was around 40. They were predominantly female. When you look at the racial ethnic background, you can see about half were Caucasian, and about 24% were African Americans. Now, this differs a little bit from the Bliss 76 trial, for which the United States was a participant. There was only about 14% African Americans enrolled, and this becomes important. This is a little more reflective of the racial ethnic background that we see in the United States of patients with lupus. Most patients were diagnosed within the past 5 years, and when you asked physicians in the community practice how they felt their patient's disease activity was at time of initiation, about 96% or so felt it was either moderate or severe. Concomitant medications, about 77% were on corticosteroids at the time they started belimumab, at a mean dose of around 20 milligrams for those who were on it. Another equal 70% were on antimalarials, and about 60% were on concomitant immunosuppressive drugs. When we talked about the main clinical organ manifestations, this is somewhat reflective of what we saw in the RCTs. This includes a majority of patients with musculoskeletal, mucocutaneous, and immunologic manifestations. About 18% or so had renal, and again, this is similar to the 16% that had renal as defined by the Salina-SLEDAI in the randomized controlled trials. And so then we asked physicians, why did you start this medicine? What were the reasons that you wanted to put somebody on Benlysta? So the top reason was for treatment regimen ineffective. But the number 2 reason is a little surprising. So despite our inability to demonstrate statistical significance in steroid sparing, almost 60% of the physicians put this drug on for the hope of the ability to decrease steroids. And so this shows that in clinical practice, we put a lot of faith in our DMARDs and their ability to allow patients to come off what we feel is a truly noxious agent in the form of corticosteroids. The other conditions included worsening patient condition, previous treatment ineffective or not well tolerated, or patient request. And so this is what we observed. So a little bit of explanation as to how we chose our endpoint. So we asked the physicians to give us an overall estimate of how they felt the patients responded. In essence, a physician global of improvement. And this was in recognition that in the community practice setting, at least in the United States, there is very little adoption of some of the more accepted research endpoints like the SLE. Indeed, only about 25% of our surveyed physicians were utilizing the SLE in their clinical practice. And so without a more widespread adoptive endpoint tool, we didn't really have a good way of asking anyone, do you have some way of telling objectively how your patient's doing? So we went with a more subjective route. We captured some objective components, which I'll illustrate to you in a second. But overall, we asked physicians, how do you think your patient did? And we divided it into percentiles of 20, 50, and 80%, really to reflect an already familiarity with percentile improvement scores from our rheumatoid arthritis experience. And so what we can demonstrate here is that overall, and if we look just at the 50% improvement as what we feel is a relatively good clinical assessment of what is a meaningful clinical improvement, almost half the patients overall were felt to have improved within 6 months of starting Benlysta. And as Rich alluded to earlier, there was a perception going into this that perhaps this medication was not going to be effective for African Americans. And what we were able to show is that indeed, at least in the eyes of the treating physician, African Americans were just as likely to respond to the same degree as the entire cohort. And this was true for all of the racial and ethnic groups that we looked at. When we looked at individual organ manifestations, the top 5 were arthritis, rash, fatigue, hypocomplementemia, and double-stranded DNA representing an objective measure. This kind of go along also with the organ domains. And we can see, again, a 50% improvement was observed in these various manifestations anywhere between 40 and 50% of the time. It wasn't heavily weighted for one clinical manifestation. The physicians whom were treating these patients felt that there was a fairly uniform improvement across multiple domains. Then we looked at steroids. So we asked if a patient was on steroids, and then again, this is 77% of the cohort, how many were able to decrease their dose? So 77% of the entire cohort was able to decrease their dose by any amount. What was really nice to see, though, is almost 10% of the patients were able to come off prednisone completely. Indeed, the overall percent drop in corticosteroid use was around 57, 58%, and very similar across all the different domains. And what that illustrates is now a drop of almost 20 milligrams a day to almost 8.4 milligrams a day, and that's quite impressive. Again, similar for African Americans as in the other cohorts. If we applied the same steroid-sparing definition as the FDA had mandated in the randomized controlled trial, which is a drop of 25% or more to a dose less than 7.5 milligrams or less, those patients that started out at greater than 7.5, 56% of them were able to get to a less than 7.5 milligrams. If we use a more rigorous dose of 5 milligrams, 47% of patients whom were over 5 milligrams at belimumab initiation were able to achieve a dose of less than 5 milligrams of daily prednisone equivalent. We also looked at health resource utilization. We asked physicians to identify hospitalizations, ER visits, etc., and compare them in the pre- and post-index period times, and we saw statistically fewer hospitalizations, fewer ER visits, fewer unscheduled visits to their treating physician, and fewer visits to other specialty physicians. If we look at another abstract that was presented in Washington, D.C. last year, we can see this is a single center observation on their use of Benlysta. This is the Hospital for Special Surgery. Again, they had a number of patients whom had been on Benlysta for a period of time, and if we look at that 6-month column, we can see that there were similar decreases in their cohort, also from Selena-SLEDAI, physician global assessments, and prednisone doses, as well as normalization of double-stranded DNA and hypocomplementemia. What about some of the other medications? Well, despite the failures of rituximab in the randomized controlled trials, we have a number of publications and illustrations that have suggested that in a real-life clinical world that there are appropriate patients for this medication. And indeed, this is one such study from Liu et al., who demonstrated in their cohort of 45 patients given rituximab that there were overall improvements in BILAG, improvements in hypocomplementemia, and reductions in double-stranded DNA titers. And this is a busy slide, but it's really to illustrate that there are a number of other biologics that have been looked at in various clinical trial and registry-based studies. Overall, the majority of the randomized clinical trials in lupus have been unfortunate in their inability to demonstrate superiority. However, most of the combined registries, and this is things from like the Corona, et cetera, that have also been able to now demonstrate that in real-life clinical practice, this perhaps may not be the case, and we have much more encouraging data to go with. So in summary, will new biologic therapies change the paradigm of treatment in SLE? Well, there is great hope to this, but time will tell. Is the methodology of RCTs reflective of the real-life management in SLE? And one can certainly argue that it is not, but maybe that's not really the point right now. The idea is to get as what we can to the market and then try it in real life to see how it really applies. But at the same time, as Dr. Merrill was talking this morning, perhaps better trial design can be more inclusive of clinical practice and how we treat our patients. Are failed RCTs the result of medication being studied, the design of the trial, or the complexity of the disease? Well, clearly it's all three. And how can we translate the results of RTTs into clinical practice? And again, this is ongoing work. So the real-world experience with belimumab, as well as other biologics in SLE, suggests that the effectiveness is seen across multiple spectra. Thank you for your time.